Hello, this video is for the module or week 6 makeup assignment, discussing major depressive disorder versus bipolar disorder 1 and 2, as well as uncomplicated grief and prolonged grief disorder. To start with, major depressive disorder is characterized by persistent sadness or loss of interest lasting at least 2 weeks. Core symptoms of this disorder can include a depressed mood, loss of pleasure, fatigue, sleep or appetite changes, feelings of worthlessness, difficulty concentrating, and suicidal thoughts. Safety risks associated with this disorder include suicide risk, especially when patients express hopelessness, withdrawal, or a sudden lift in mood after severe depression. Some nursing assessment priorities that I would keep in mind with this disorder would be to assess their mood and affect. You want to ask directly about suicidal ideation, evaluate their sleep, their appetite and functioning, how it's affecting their daily life, and then also determine their support system. Nursing interventions for major depressive disorder would include providing emotional support, encouraging routine and small achievable goals, monitor medication effects, promote safety if suicidal thoughts are present, and helping educate on different coping skills and strategies. A therapeutic statement that I would make for a patient suffering from major depressive disorder would be that I'm really glad you shared that with me. You don't have to go through this alone. For bipolar 1 and bipolar 2, both disorders involve mood swings between depression and elevated mood, but they differ in severity. With bipolar 1, it requires at least one manic episode. The manic episode is severe and distinct, and it lasts for at least 7 days or more. It can cause major impairments in the individual's life. Symptoms of bipolar 1 can include high activity levels, a decreased need for sleep, psychosis, racing thoughts, impulsive decisions, pressured speech, which would be your rapid, frenzied, loud, and uncontrollable speech and is difficult to interrupt them. Mania, like I said, lasts for about 1 week or more and causes major impairment. Bipolar 1 can also include psychosis or hospitalization in severe cases. For bipolar 2, this includes hypomania, which is a less severe form of mania. This is also characterized by abnormal and elevated mood, increased energy, and high energy that lasts for at least 4 days. This lasts for 4 days instead of 7 that we would see in bipolar 1. Symptoms can include euphoria or extreme irritability, decreased need for sleep, talkativeness, racing thoughts, and high energy, just like in bipolar 1. However, in bipolar 2, hallucinations and delusions do not occur, and hypomania and hospitalization rarely occurs. This is a more manageable form of mania that does not cause severe major impairment in an individual's daily life. However, left untreated, hypomania can progress to full mania. Depression episodes are often more frequent as well in bipolar 2. Key differences between these two are going to be your severity, how long it lasts, and then like I said in bipolar 1, psychosis and hospitalization can occur, whereas in bipolar 2 it very rarely occurs, and psychosis does not occur in bipolar 2. Safety risks for mania especially, you want to look at their own impulsivity, risky behaviors, and poor judgment. For example, if they're engaging in risky sexual behavior, you are going to need to educate them on STDs, pregnancies, unsafe situations, or if they are engaging in financial decisions, it can lead to poor credit, going into debt, things like that. For safety risks for the depression phase, you are going to want to watch out for a suicide. Risk for suicide is very high. Nursing assessment priorities for patients with bipolar 1 and bipolar 2 would be monitoring their sleep patterns, assessing for that, because decreased sleep can signal mania. You also want to assess their speech speed and their thought processes, assess for risk-taking behaviors, and as well as medication adherence. Interventions for bipolar 1 and bipolar 2, specifically for mania, would be to reduce stimulation, set clear limits, provide simple directions, and monitor their nutrition and sleep. For bipolar depression, the depression phase, you want to go with the same approach as major depression care. Provide emotional support, encourage routine and small achievable goals, monitor medication effects, and promote safety if suicidal thoughts are present, as well as monitoring closely for suicide risk. You can also educate and implement coping strategies and skills with these patients as well. A therapeutic statement that I would use for a patient that is suffering from bipolar 1 or bipolar 2 would be, I've noticed you've had a lot of energy and haven't slept much. Can you tell me what that's been like for you? For uncomplicated grief versus prolonged grief disorder. Uncomplicated grief is a normal response to loss. It can include the 5 stages of grief, including sadness, crying, and longing. However, this does improve over time. The person can still function. Characteristics can include sadness, anger, loneliness, and in time they can accept their new reality. In prolonged grief disorder, it is a persistent, intense grief lasting longer than 12 months in adults, 6 months in children. The person feels stuck in their grief. They have severe emotional pain. It impairs their daily functioning. And characteristics for prolonged grief disorder is intense yearning or longing for the deceased member, emotional numbness, identity loss, disbelief, and avoidance of reminders. The key differences between uncomplicated grief and prolonged grief disorder is that with normal grief they can move forward, and it can be slow, but with prolonged grief disorder they cannot move forward. It stays intense and it's disabling. With grief, it's not disabling. Safety risks can include social isolation, depression, substance use, and suicide risk if hopelessness develops. And this involves uncomplicated grief as well as prolonged grief. Nursing assessment priorities for these patients would be time since the loss has occurred, whether or not they're coping, if they have a support system, and the impact on their function in daily life. Interventions for these disorders are encouraging expression of feelings, validate emotional responses, provide grief education, and refer to counseling if the symptoms persist or worsen. A therapeutic statement that I would use for these patients would be to say, grief looks different for everyone. I'm here to listen whenever you want to talk about your loss. In summary, major depressive disorder involves persistent low mood and suicide risk. Bipolar 1 versus 2 differ mainly in severity of manic symptoms and how long they last. And normal grief or uncomplicated grief versus prolonged grief disorder also differs in the duration and the level of impairment. Thank you.